All right, everyone, welcome to the stomach. And yes, this is where things start getting acidic, both chemically and emotionally, for the cheeseburger that just entered the chat. The stomach is not just a holding tank for poorly chewed food decisions. It is a highly specialized organ designed for mechanical breakdown, chemical digestion, and controlled delivery into the small intestine. Let's orient ourselves anatomically first. We divide the stomach into 5 major regions. The cardia is the welcome mat from the esophagus. The fundus is the dome that likes to collect swallowed air. Fun fact, this is why percussion sounds different here. Body, the main acid-producing powerhouse. The antrum is the grinder, and the pylorus, the gatekeeper controlling gastric emptying. Think of the pylorus as the nightclub bouncer of the GI tract. You, glucose molecule, go ahead. You, giant chunk of steak, absolutely not. Now let's talk about the omentum, because histotechs sometimes forget this exists until they gross a specimen and go, wow, that is a lot of yellow tissue. The greater omentum is that apron-like fatty structure hanging off the greater curvature. Worthless but fantastic knowledge, it is sometimes called the policeman of the abdomen, because it can migrate toward areas of inflammation and help wall off infection. Basically, the body invented internal crime scene tape. The lesser omentum is thinner and connects the stomach to the liver. From a specimen handling perspective, expect fat, respect the fat, do not underestimate how long it takes to fix properly. Fat is the diva of tissue processing. This is the slide where histotechs should feel at home. When you look at stomach tissue under the microscope, the layering is beautifully organized. Classic GI architecture. Starting from the lumen outward, you have mucosa. This is where the magic happens. You'll see gastric pits, gastric glands, and specialized cells like parietal cells, which are the acid factories, and chief cells, which are producing pepsinogen. Fun memory trick here, parietal equals proton pumps, and chief equals protein digestion. If parietal cells disappear, start thinking autoimmune gastritis. If they go into overdrive, hello ulcers. You have the submucosa. This is the support layer. It contains vessels, nerves, and connective tissue. It's also home to part of the enteric nervous system, which, fun fact, can function independently of the brain. Yes, your gut literally has decision-making abilities, which explains emotional eating a little too well. And then there's the muscularis propria. Unlike most of the GI tract, the stomach has 3 layers of muscle: the oblique, the circular, and the longitudinal. This is why the stomach can churn food into what is medically known as chyme, or what I call a digestive smoothie. Serosa. It's the outer covering. It's smooth and protective. From a lab standpoint, when embedding full-thickness gastric samples, orientation matters. Otherwise, your pathologist gets abstract art instead of anatomy, and they do not enjoy surprises. Gastritis simply means inflammation of the stomach, but the cause, and therefore what we see histologically, can vary dramatically. We broadly divide it into acute gastritis, so think sudden mucosal injury. Some common culprits would be NSAIDs, alcohol, heavy smoking. And mechanism highlight or a histo brain moment. NSAIDs inhibit prostaglandins, decreased mucus production, and acid gets bold, so there's mucosal damage. Classic microscopic findings, we'd have edema, hyperemia, and neutrophils, your inflammation first responders. Then there's chronic gastritis. Now we're playing the long game. Inflammation persists, mucosa begins to change, and atrophy may develop. And whenever tissues start adapting, histotechs should quietly whisper, metaplasia is coming, because it often is. Gastritis had a celebrity spokesperson, it would absolutely be Helicobacter pylori. This organism is responsible for the majority of chronic gastritis worldwide. And honestly, it is biologically fascinating. Let's appreciate the design. They're spiral shaped, flagellated, and built to burrow through mucus. Basically, the GI tracks tiny corkscrew invader. Even cooler, it produces urease, which converts urea into ammonia. That ammonia creates a protective alkaline cloud so the bacterium can survive stomach acid. Imagine bringing your own force field to a volcano. When you suspect H. pylori, routine H&E may show them, but special stains make them shine, such as the Giemsa, the Warthin starry, or some immunohistochemistry. And once you've seen them, you never unsee them. They look like little curved commas partying along the epithelial surface. Transmission is fecal-oral route, which is your gentle reminder that hand hygiene is not just a hospital suggestion. It is a lifestyle. Clinical relevance worth knowing. Chronic H. pylori infection increases risks for peptic ulcer disease, gastric adenocarcinoma, and MALT lymphoma. So this is not just background inflammation. This is tissue remodeling with consequences. Treatment, antibiotics plus proton pump inhibitors, meaning yes, this is one of the few GI diseases we can actually eradicate rather than just manage. The stomach breathes a sigh of relief. Quick fun fact, about 50% of the world's population carries H. pylori, but many never develop symptoms. So remember, presence does not equal disease. Context matters, pathology's favorite phrase. All right, let's talk about one of the most successful microbial squatters in human history. Again, Helicobacter pylori. This organism is basically the survivalist champion of the gastric world. Remember, the stomach is sitting at a pH that can rival battery acid, and yet this little spiral bacterium not only survives, it thrives. So how does it pull that off? First, flagella. These allow H. pylori to corkscrew its way through the protective mucus layer. Think of it like swimming and more like tunneling. Think of it less like swimming and more like tunneling. It wants to get close to the epithelial surface where the pH is a bit friendlier. Next, the star of the show, urease. This enzyme breaks down urea into ammonia, creating a localized alkaline cloud around the bacterium. Yes, it basically carries around its own chemical antacid. From a histotech perspective, this is why you often see organisms nestled along the mucosal layer rather than floating freely in the lumen. Then we have adhesins, which allow the bacteria to latch onto foveolar cells, because apparently invading wasn't enough. Now it wants permanent residency. And finally, toxins, which trigger epithelial injury and chronic inflammation. Another important clinical pattern. H. pylori prefers the antrum. That region produces less acid than the body and fundus, making it prime real estate. Now here's the part worth remembering, conceptually. Chronic inflammation equals cellular turnover, and cellular turnover increases mutation risk, which is why chronic H. pylori gastritis is associated with gastric adenocarcinoma and MALT lymphoma. Roughly half the world's population again carries H. pylori, but most never know it. The scientists who proved H. pylori causes gastritis had such a hard time convincing people that one of them literally drank the bacteria to prove the point. Commitment level equals extreme. Now let's shift gears into what you care about most, what this slide looks like on a slide. On the Warthin starry silver stain, those tiny curved bacilli show up as dark little squiggles hugging the epithelial surface. If you've ever thought, are those bacteria or just stain precipitant? Welcome to the club. Silver stains keep us humble. On H&E, you may not always clearly see the organisms, but you will see the inflammatory response. Classic features include neutrophils infiltrating the lamina propria. Sometimes neutrophils migrating into pits, creating what we call pit abscesses. And then there's lymphoid aggregates, so plasma cells beneath the epithelium. Those lymphoid aggregates are especially important because normal stomach mucosa typically does not have organized lymphoid tissue. So when you see it, your brain should whisper, something chronic is happening here. And a histotech tip, good fixation is critical for gastric biopsies. Autolysis hits GI tissue fast, and once epithelial detail is gone, interpretation becomes much harder. Some worthless but interesting knowledge. Pathologists sometimes jokingly refer to H. pylori as looking like seagulls in flight. Once you see it, you can't unsee it. Now let's talk about a very different mechanism of injury, one where the body decides to attack itself. Autoimmune gastritis targets parietal cells and intrinsic factor. Quick physiology refresher: parietal cells produce hydrochloric acid, intrinsic factor, which is essential for vitamin B12 absorption in the ileum. Destroy the parietal cells, lose intrinsic factor, and now B12 absorption fails. Enter pernicious anemia. Patients may present with classic anemia symptoms: fatigue, pallor, but the neurologic findings are what often stand out: tingling hands and feet, peripheral neuropathy, and cognitive changes, and the famously described beefy red tongue. Histologically, autoimmune gastritis tends to affect the body and fundus rather than the antrum, the opposite distribution of H. pylori. Over time, you'll see mucosal atrophy, loss of parietal and chief cells, and intestinal metaplasia. And again, chronic injury increases cancer risk, particularly adenocarcinoma and sometimes carcinoid tumors, due to neuroendocrine cell hyperplasia. Fun fact: because acid production drops, patients often develop hypergastremia. The body keeps yelling, "Make acid," but nobody is home to do it. All right, let's finish this section with something you will absolutely encounter in surgical pathology: peptic ulcers. A peptic ulcer is essentially a localized area where mucosal defenses lost the battle against acid and pepsin. Most commonly, these occur in the proximal duodenum, but gastric ulcers are certainly not rare. Major players include H. pylori, NSAIDs, and smoking. NSAIDs are particularly sneaky. They inhibit prostaglandins, which normally help maintain the protective mucus barrier. No prostaglandins equals a weaker mucosal defense. Grossly, ulcers are often described as punched out. Sharp margins, clean base, almost like someone used a biopsy punch. Histologically, classic layering can sometimes be appreciated. So necrotic debris, acute inflammation, granulation tissue, and fibrosis. It's basically a timeline of injury and repair stacked vertically. Histotech Pearl: when embedding ulcer biopsies, orientation matters. Getting mucosa perpendicular to the cutting surface allows the pathologist to evaluate depth, which can be clinically meaningful. Worthless knowledge to close us out: before we understood H. pylori, stress was blamed for nearly all ulcers. Turns out the stomach isn't nearly as emotionally fragile as we once thought. All right, histotechs, let's talk about what this looks like when it walks into the clinic. The classic symptom is epigastric pain. Patients often describe it as gnawing or burning. And yes, if you've ever skipped meals during finals week and felt your stomach plotting revenge, you already have a tiny conceptual framework for this. Some patients experience weight loss, vomiting, diarrhea, and interestingly, some patients are completely asymptomatic, which is both fascinating and mildly terrifying, because the first sign might be bleeding or perforation. Nothing says medical emergency quite like gastric contents leaking into the peritoneum. When these come to biopsy, what are you looking for? Classic ulcer architecture shows necrotic debris on the surface, acute inflammatory infiltrate, granulation tissue, and fibrosis deeper down. Think of it as a 4-layer dip of tissue injury, not a party dip. Please don't remember it that way. Treatment. Thankfully, modern medicine has given us proton pump inhibitors, basically telling the stomach, calm down with the acid production. And of course, if H. pylori is present, we eradicate it. Fun fact: before H. pylori was discovered, again, in the 1980s, people blamed ulcers not only on stress, but also spicy food. 2 researchers literally drank the bacteria to prove causation, again, yes, on purpose. Their histology bravery level was legendary. Now let's zoom out and talk tumors, because the stomach can grow quite the variety. Benign tumors, it's good news at first. Polyps, these are mucosal protrusions, little architectural overachievers, but remember, some adenomas are precancerous, so they absolutely matter. Histologically, you may see dysplastic epithelium, nuclear stratification, loss of polarity, basically cells forgetting how to behave in polite epithelial society. There's leiomyomas. These are smooth muscle tumors. If it looks like organized fascicles of spindle cells with cigar-shaped nuclei, congratulations, you are staring at smooth muscle doing smooth muscle things. Lipomas, composed of mature adipocytes. Honestly, they look so normal under the scope that if they had personalities, they'd apologize for taking up space. Malignant tumors, and here is the heavy hitter. Adenocarcinoma is about 90% of all gastric cancers. Let that number stick. When someone says gastric cancer, this is usually what they mean. Others include lymphoma and sarcomas, but adenocarcinoma runs the show. Some worthless but fun knowledge. The stomach is actually a surprisingly hostile place for tumor development because of the acid. So when cancers arise here, they've evolved some serious survival skills. There are two major growth patterns you should recognize. The intestinal type, think bulky, exophytic, ulcerated. These tumors often form gland-like structures histologically, very wannabe intestinal epithelium. Risk factors often include chronic gastritis, H. pylori, and intestinal metaplasia. It follows a stepwise mutation pathway, which pathologists appreciate because it makes biological sense. Unlike chaos tumors. We dislike chaos tumors. Then there's diffuse type. This one is sneakier. Instead of forming a mass, it thickens the stomach wall. No polite tumor border, no architectural respect. Histologically, hello signet ring cells. These cells are packed with mucin that shoves the nucleus off to the side, like someone hogging the couch. The result? The stomach becomes rigid. You may hear the term Linitis plastica, leather bottle stomach, not a phrase you forget. Location pearl most commonly occurs in the antrum along the lesser curvature. Feast your histotech eyes on these specimens. Notice how irregular and infiltrative these tumors appear. This is not tidy growth. This is architectural rebellion. When grossing these, sampling is everything. Because tumor heterogeneity is real. One area might be well differentiated while another looks like cellular anarchy. Pro tip for future practice, always sample tumor margins, deep invasion, adjacent mucosa, and any suspicious lymph nodes. You are staging the disease before the pathologist ever signs the case out. No pressure. Globally, gastric cancer is far more common in East Asia. Why? Likely a combination of diet, salt preservation, and nitrosamines, and H. pylori prevalence. Pathology is never just microscopic. It reflects culture, environment, and behavior. Pretty incredible when you think about it. Okay. Let's talk about the diffuse type of gastric adenocarcinoma, sometimes lovingly referred to as the tumor that refuses to respect normal architecture. Unlike the intestinal type that forms bulky, somewhat obvious masses, the diffuse type infiltrates the stomach wall like an uninvited house guest who slowly rearranges your furniture without asking. Grossly, what you're seeing here is dramatic thickening of the gastric wall. Instead of nice, pliable rugae, the stomach becomes rigid and leather-like, a condition again called linitis plastica, which literally translates to leather body stomach, bottle stomach. And yes, it feels as flexible as a leather water bottle from the 1800s. A histology connection? Microscopically, this tumor is famous for signet ring cells. These cells are packed with mucin that pushes the nucleus off to the side, giving it that classic ring appearance. Fun fact, once you see signet ring cells, your brain will never stop spotting them. It's like buying a red car and suddenly noticing every red car on the highway. Because these tumor cells infiltrate individually rather than forming glands, the stomach wall thickens without creating a large discrete mass, which means less obvious lesion, more subtle early symptoms. It's often detected later. Not ideal, Worthless knowledge moment here. Diffuse gastric cancer has been linked to mutations in the CDH1 gene, which affects E-cadherin, the molecular Velcro that normally helps epithelial cells stick together. Lose the Velcro and cells wander. And wandering cells are rarely polite. Now let's shift gears slightly, because not every stomach malignancy originates from epithelial cells. Some arise from the immune system. Gastric lymphomas typically develop in areas of chronic inflammation, and one of the biggest instigators is, you guessed it, H. pylori. This organism just keeps showing up everywhere in GI pathology, like it owns the place. Normally, the stomach does not contain much organized lymphoid tissue, so when chronic infection stimulates lymphoid proliferation, you essentially build acquired lymphoid tissue within the mucosa. Over time, that proliferation can become monoclonal or malignant. Many gastric lymphomas are MALT lymphomas, mucosa-associated lymphoid tissue. Microscopically, you'll see dense lymphocytic infiltrates, destruction of normal glands, and sometimes lymphoepithelial lesions. Grossly, these tumors can appear as small nodules, thickened folds, or diffuse infiltration. Not always dramatic, but definitely disruptive. A fun clinical pearl: early gastric MALT lymphomas can sometimes regress if the H. pylori infection is eradicated. Yes, treating a bacterial infection can cause a lymphoma to disappear. Pathology is wild. Worthless knowledge bonus: the stomach basically says, I don't normally do lymph nodes, but fine, I'll grow some if you keep irritating me. Chronic inflammation is a powerful architect. Carcinoid tumors are part of the neuroendocrine tumor family, meaning they arise from hormone-producing cells scattered throughout the GI tract. Think of neuroendocrine cells as tiny biochemical messengers quietly regulating digestion, until they decide not to be quiet anymore. These tumors are typically well differentiated, slow growing, firm, and yellow-tan on cut surface. That yellow color, often due to lipid-rich cytoplasm. Under the microscope, you'll see beautifully organized nests or trabeculae of uniform cells, very orderly, almost suspiciously polite for a tumor, in a classic chromatin pattern. Salt and pepper. Once you recognize it, you never forget it. Worthless knowledge here: pathologists love food metaphors. Salt and pepper chromatin, ground glass nuclei, oat cells. Apparently pathology is just one long dinner menu. These tumors usually sit within the wall beneath the mucosa, which explains why they may create a submucosal bulge rather than an ulcerated surface lesion. Depending on hormone production, some neuroendocrine tumors can trigger systemic symptoms, but many gastric carcinoids are found incidentally, quiet, sneaky, and structured. The overachievers of the tumor world. Now we arrive at the heavyweight champion of mesenchymal gastric tumors, the gastrointestinal stromal tumor, or GIST. If gastric adenocarcinoma is the celebrity, GIST is the quietly important specialist. These tumors originate from the interstitial cells of Cajole, which function as the pacemaker cells of the GI tract. Yes, your gut has a rhythm section. Peristalsis is basically a coordinated wave choreographed by these cells. When they go rogue, we get GIST. Gross appearance is they are often large, well circumscribed, fleshy, and sometimes up to 30 centimeters, which is roughly the size of a newborn. Let that sink in. Yet many grow outward from the stomach wall rather than invading early, so symptoms can be delayed. Histology patterns: there are two major morphologies. There's a spindle cell type, which is elongated, sweeping fascicles, and then there's an epithelioid type, which are rounder cells. Immunohistochemistry is hugely helpful here. Most GISTs are KIT positive, reflecting mutations in a receptor tyrosine kinase. Fun fact: GIST helped revolutionize targeted cell therapy because drugs were designed specifically to inhibit that mutated receptor. A beautiful example of molecular pathology directly shaping treatment strategies. Before we understood KIT mutations, many of these tumors were misclassified as leiomyomas or leiomyosarcomas. Moral of the story: As diagnostics improve, tumors get reassigned like academic majors. All right, let's zoom back out anatomically for a moment. The small intestine is about 600 centimeters long, which is honestly impressive when you consider it has to fit into the abdominal cavity without tying itself into knots. Evolution did some excellent spatial planning here. It is divided into three segments: the duodenum, the jejunum, and the ileum. Each one has specialized absorptive roles, and yes, those differences matter histologically. The major function is absorption, but not all nutrients are absorbed equally along the tract. The duodenum is iron absorption. The terminal ileum is vitamin B12. That terminal ileum detail becomes clinically important because when it is diseased or resected, patients can develop megaloblastic anemia due to impaired B12 absorption. From a histotechnologist's perspective, remember, the small intestine is built for surface area. Between plicae circularis, villi, and microvilli, this organ massively increases absorptive capacity. If you could flatten it out, the surface area, again, is roughly comparable to a tennis court, which is a fun piece of worthless knowledge that is actually very useful when thinking about disease impact. Damage even a portion of that surface, and absorption efficiency drops quickly. Now look at this section. Immediately your eye should go to the villi, those tall finger-like projections extending into the lumen. Key structures to recognize is the simple columnar epithelium, the goblet cells, and the lamina propria within each villus, and the muscularis below. Each villus contains capillaries and a lacteal, allowing simultaneous absorption of amino acids and sugars into the bloodstream, then convert to lipids and then into lymphatics. Very elegant design. Histology tip: the height of villi often correlates with absorptive health. When diseases damage the mucosa, the villi can become blunted, atrophic, or flattened, which dramatically reduces absorptive surface. This is why some patients with mucosal disorders develop malnutrition even when they are eating adequately. Another thing to appreciate, the epithelium here turns over rapidly. These cells live hard and die young, constantly replaced by stem cells in the crypts. The GI tract is one of the best examples of controlled cellular regeneration in the body. Now we transition from absorption to reclamation and storage. The colon is divided into several segments: the cecum with appendix, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and the rectum, and the anus. Its major functions are water absorption, electrolyte balance, and waste storage. By the time contents reach the colon, most nutrients are already gone. What remains is concentrated into fecal matter. A fun physiologic perspective: if the colon didn't reclaim water efficiently, we would lose liters of fluid daily. So yes, it quietly prevents chronic dehydration. The muscular sphincter controlling defecation is also worth mentioning because it highlights the transition from involuntary to voluntary control within the GI tract. Your body knows when it's time, but society prefers you choose the location wisely. First impression compared to the small intestine: no villi. That is one of the fastest ways to distinguish these organs under the microscope. Instead, you see straight tubular glands, abundant goblet cells, and a smooth luminal surface. Why so many goblet cells? Lubrication. As stool becomes more solid, mucus helps reduce friction and protects the mucosa. Remember, as a layer review, we have mucosa, submucosa, the tunica muscularis, and the serosa. Another histology pearl: the colon has a heavy bacterial load, yet the mucosa is typically not inflamed. That tells you how effective the mucosal barrier and immune regulation are. When that balance is disrupted, pathology follows. Also notice the muscularis, organized for strong peristaltic contractions capable of moving increasingly solid material forward. No glamorous work, but absolutely essential. All right, let's shift gears into something that can become a true surgical emergency: intestinal obstruction. At its core, obstruction simply means something is blocking the forward movement of intestinal contents. And remember, The intestine is not a passive tube. It is constantly moving via peristalsis. When that movement meets a roadblock, pressure builds quickly. Think of it like a highway closure at rush hour. Traffic doesn't just politely stop, it backs up for miles. The major mechanical causes listed here are ones you will absolutely encounter in surgical pathology: herniation, adhesions, volvulus, and intussusception. And then we have additional culprits like tumors, infarction, and Crohn's disease. Anything capable of narrowing the lumen or distorting the bowel architecture. When obstruction progresses, compromised blood flow can lead to ischemia, then necrosis, and then possible perforation. So the specimen you receive may not just be bowel, it may be dusky, infarcted bowel, and your fixation becomes critically important for preserving tissue morphology. Pro tip: open obstructed bowel promptly when appropriate. Trapped bacteria accelerate autolysis. Worthless knowledge: the small intestine can tolerate distension surprisingly well. The colon, not nearly as forgiving. That's why cecal perforation is such a feared complication. These images nicely illustrate the four big mechanical players. Let's walk through them conceptually. Herniation. A segment of bowel pushes through a structural weakness. Once trapped, venous return is compromised first, which is why the bowel becomes congested and purple before arterial flow is lost. Adhesions. These are bands of fibrous scar tissue, most commonly from prior surgery. Imagine shrink wrap tightening around a loop of bowel. From the lab side, adhesion cases often come with multiple segments and complex orientation, so careful gross description matters. Volvulus. This is a twist of the bowel around its mesentery. Think wringing out a wet towel. Not only is the lumen blocked, the blood supply is literally strangled. Sigmoid volvulus is a classic example. Then we have intussusception. One segment telescopes into another. Yes, telescopes are apparently not just for pirates. In adults, always consider a lead point, often a tumor. Histology angle: with any of these, watch for mucosal sloughing, hemorrhage, and transmural necrosis. These specimens tell a story, and it is rarely a happy one. Let's zoom in a bit more on hernias, since they are the most frequent cause of intestinal obstruction worldwide. A hernia occurs when a defect in the abdominal wall allows a serosa-lined pouch of peritoneum, the hernia sac, to protrude outward. Common locations include inguinal, femoral, and umbilical, as well as prior surgical sites. Basically, anywhere the wall is weaker than Mother Nature intended. Why we care clinically? The danger is not the protrusion itself, it's incarceration. When the bowel gets stuck, followed by strangulation, when blood supply is compromised. Strangulated bowel often appears dark red to purple, edematous, possibly green-black if necrotic. It is not subtle. Histotech pearl: these are high bacteria load specimens. Fix generously. Avoid delayed processing. Your microtomy blade will thank you. A fun analogy here: think of strangulated bowel like a kinked garden hose, except instead of water pressure, we're dealing with vascular collapse. Much higher stakes. Now this is a specimen that practically screams the diagnosis. Notice the dusky discoloration that is vascular compromise. When venous outflow is obstructed, blood pools, oxygen drops, and then tissue dies. If untreated, this progresses to gangrene and perforation. And once bowel perforates, we're talking peritonitis, which is a whole different level of clinical urgency. What should you anticipate histologically? Well, expect to see hemorrhagic infarction, coagulative necrosis transitioning toward liquefactive change, heavy acute inflammation, and sometimes the mucosa is completely gone. When you encounter bowel like this, document color carefully, measure affected segments, and describe the transition from viable to non-viable tissue. Surgeons love that information. It correlates with what they saw intraoperatively. A slightly morbid but fun fact: ischemic bowel can lose viability in as little as 6 hours. The intestine is productive, but dramatic. Let's talk about one of the most common troublemakers inside the abdomen: adhesions. Think of adhesions as the body's version of duct tape. Something gets inflamed, surgery, infection, endometriosis, and the healing process lays down fibrous tissue that essentially says, you two organs should stay together forever. Unfortunately, they were never meant to. These fibrous bridges can trap loops of bowel, creating an internal hernia. Once that loop is stuck, we can see obstruction, compromised blood flow, strangulation, and eventually infarction if the tissue becomes ischemic. From a histology perspective, adhesions are largely dense, collagenous connective tissue, not particularly glamorous under the microscope, but very clinically significant. You'll often see fibroblast proliferation transitioning into mature fibrotic bands. After abdominal surgery, adhesions form in up to 90% of patients, yet many never know they have them. Some worthless knowledge? Surgeons sometimes refer to reoperating on an abdomen full of adhesions as entering a hostile abdomen, not exactly a 5-star Yelp review for the peritoneal cavity. Take a look at this image. What you're seeing are those fibrous bands physically tethering bowel loops together. Notice how the intestine loses its normal mobility. Remember, the bowel is designed to glide smoothly within the peritoneal cavity. When adhesions anchor it down, peristalsis becomes a mechanical nightmare. Histotechnologists don't often receive an adhesion specimen by itself, but you will see the downstream effects: ischemic bowel, necrosis, and inflammatory changes. If this tissue were sectioned, expect to see dense collagen, fibroblasts, possible chronic inflammatory infiltrates, and sometimes neovascularization, basically scar tissue that overstayed its welcome. An analogy here: imagine earbuds in your pocket, perfectly fine when separate, absolute chaos when tangled. Same energy. Now let's twist things up literally. A volvulus occurs when a loop of bowel twists around its mesenteric attachment. This creates a twofold problem. The lumen closes, which creates obstruction. Blood vessels compress, which causes ischemia. And bowel tissue is extremely unforgiving when deprived of oxygen. The sigmoid colon is the classic location because it tends to have a longer mesentery, meaning more freedom to rotate. Too much freedom, apparently. Histologically, early volvulus may show congestion, edema, hemorrhage, and progression leads to coagulative necrosis, loss of mucosal architecture, and inflammatory infiltration. Fun fact, on imaging, sigmoid volvulus often creates what radiologists call the coffee bean sign. Once you see it, you cannot unsee it. Some worthless knowledge: the word volvulus comes from Latin meaning to roll, which is medically accurate and mildly unsettling. If volvulus is twisting, intussusception is telescoping. One segment of intestine literally slides into the adjacent distal segment. Picture one collapsible telescope sliding into itself, except now it's dragging mesentery along, compressing vessels, and setting the stage for obstruction and infarction. In pediatric cases, this is often triggered by lymphoid hyperplasia, especially in Peyer's patches following viral illness. The enlarged lymphoid tissue creates a lead point that initiates the telescoping. Adults are different. When intussusception shows up later in life, we immediately start thinking about a structural cause, like a tumor acting as that lead point. Histologically, compromised areas may show mucosal sloughing, hemorrhage, and ischemic necrosis. Clinical pearl for tissue folks: always respect bowel that looks dusky or hemorrhagic. Ischemic intestine can deteriorate fast. Fun fact, reduction using an air or contrast enema is often successful in children, one of the rare times radiology doubles as treatment. Analogy: ever accidentally push part of a sock into itself while folding laundry? It's the same concept, just dramatically worse consequences. All right, take a look at this specimen. What you're seeing here is a mechanical obstruction caused by a tumor. Unlike adhesions or volvulus, which twist or trap bowel, this is a space-occupying lesion, physically narrowing the lumen. Classic pathology principle: anything that reduces lumen diameter increases resistance to flow. Think of it like stepping on a garden hose. Eventually nothing gets through. Now histotechnologist brain. What should you already be thinking? Where is the tumor originating? The mucosa? The submucosa? Is it infiltrative or well circumscribed? What margins might need evaluating? Are we seeing ulceration? Clinically, tumors often cause progressive obstruction, not sudden. Patients typically present with gradually worsening constipation, abdominal distension, pain, and sometimes occult bleeding. And here is a high-yield connection. Left-sided colon cancers tend to obstruct earlier because the lumen is smaller and stool is more solid. Right-sided tumors, they often grow silently, sneaky little devils. From a processing standpoint, these resections are margin-heavy cases, so orientation and inking matter enormously. Now we shift gears into functional symptoms, things clinicians hear every single day. Constipation, defined as infrequent or difficult evacuation. Two major contributors listed here, low fiber and aging. Why aging? Because gut motility slows, smooth muscle tone declines, and neural regulation becomes less efficient. Histologically, you usually won't see dramatic structural abnormalities. This is more physiology than morphology. The diarrhea, increase in stool mass, frequency, or liquidity. And yes, that greater than 14 liters bullet is intentionally dramatic because severe fluid loss equals electrolyte imbalance, which can turn into hypovolemic shock and even death if untreated. Mechanistically, diarrhea falls into categories like secretory, osmotic, inflammatory, or malabsorptive. You don't need to memorize them, just understand there are multiple pathways. Then there's dysentery. Now this one does scream pathology. It's painful, bloody diarrhea usually indicates mucosal invasion, tissue destruction, inflammatory response. So unlike functional diarrhea, something is actively damaging the bowel lining. IBS, or irritable bowel syndrome, is one of the most common GI diagnoses and also one of the most misunderstood. Let me say something very clearly. IBS is a functional disorder. There is no identifiable structural pathology, meaning when biopsies come to the lab, they often look completely normal. And students always ask, how can someone feel this bad if nothing is wrong histologically? Because the problem is gut-brain signaling, motility dysregulation, and visceral hypersensitivity. The bowel is essentially overreacting. Key demographic pattern, we'll see ages 20 through 40, female predominance. Diagnosis is clinical, based heavily on symptom patterns. You notice the improvement after defecation. That's important contrast for you. IBS is functional. IBD or Crohn's or ulcerative colitis is structural inflammation. Do not mix those up, okay? We divide GI bleeding into upper versus lower, and this distinction helps clinicians narrow the differential fast. So upper GI includes esophagus, stomach, and the first portion of the duodenum. Common causes you'll eventually study are peptic ulcers, esophageal varices, Mallory-Weiss tears. Patients often present with hematemesis, which is vomiting blood, melena, which is black tarry stool caused by digested blood. Remember that phase, digested blood, okay? Then there's the lower GI, anything distal to the proximal duodenum. Patients typically show hematochezia, which is bright red blood. Why bright? Because it hasn't been exposed to digestive enzymes long enough to darken. For histotechnologists, bleeding cases often mean biopsies searching for tumors, inflammatory disease, vascular lesions, and ischemic injury. So while clinicians stabilize the patient, we help identify the cause. Now that we've separated upper from lower GI bleeding, let's talk about what that actually looks like clinically. Hematotemesis is bloody vomiting. If the blood is bright red, that usually means relatively fresh bleeding, something active and closer to the esophagus or stomach. But when you hear the phrase coffee ground emesis, that is partially digested blood. Gastric acid denatures hemoglobin and turns it that dark brown granular color. Think of it like dropping a white t-shirt into coffee. The longer it sits, the darker it gets. From a pathology standpoint, common culprits include gastric ulcers, esophageal varices, severe gastritis, and Mallory-Weiss tears. Now contrast that with hematochezia, which is bright red blood per rectum. This usually suggests a lower GI source, often colon or rectum, because the blood hasn't had time to be digested. However, and this is important clinically, a massive upper GI bleed can sometimes move so quickly through the tract that it presents as hematochezia. Your bowel does not always follow textbook rules. It likes chaos. When you see colon resections for bleeding, always examine the mucosa carefully for angiodysplasia, diverticula, tumors, and ulcerations. Sometimes the growth looks subtle, but the microscope tells the real story. Now we move into the darker side, literally. Melena is that classic black, tarry stool caused by digested blood. It typically means the blood originated higher in the GI tract, often proximal small bowel or above, because it takes time for enzymes and bacteria to break down the hemoglobin. A fun but mildly gross fact, it takes only about 50 to 60 milliliters of blood in the stomach to produce melena. This is less than a shot glass. Bodies are efficient storytellers. Now let's talk about occult bleeding. Occult means hidden. Patients may have no visible blood, but lab tests detect it. This is why fecal occult blood testing is such an important screening tool, especially for colorectal cancer. Slow, chronic bleeding can lead to iron deficiency anemia, which is often the first clinical clue. Histotech Pearl: never underestimate tiny mucosal lesions. Small adenomas and early carcinomas bleed just enough to matter clinically. The microscope catches what the naked eye misses. Malabsorption is exactly what it sounds like. The intestine is failing at one of its primary jobs, absorbing nutrients. And when absorption fails, the entire body feels it. Patients often present with chronic diarrhea, weight loss, muscle wasting, abdominal distension, and loud berbergimi. I can't pronounce that, which is a very fancy word for stomach growling, okay? Seriously, it sounds like a coffee percolator. The hallmark sign is steatorrhea, which is fatty stool. If you've never seen it in clinical description, it's bulky, pale, greasy, and floats. Yes, it floats. Fat is less dense than water. Physics always wins. So common causes include pancreatic insufficiency, so not enough digestive enzymes, celiac disease, so immune-mediated villus destruction, Crohn's disease, so inflammatory damage and reduced absorptive surface, histotechnology connection. When processing small bowel biopsies for suspected malabsorption, orientation is everything. If the villi are not standing upright, you cannot accurately evaluate villus atrophy, crypt hyperplasia, and intraepithelial lymphocytes. So bad orientation equals bad diagnosis. Again, no pressure. Most people immediately associate cystic fibrosis with the lungs, and yes, pulmonary disease is the major life-limiting factor. But histotechnologists should always remember CF is a multi-system glandular disease. It all comes back to a mutation in the CFTR gene, which disrupts chloride and bicarbonate transport. Translation: water doesn't follow the ions. Secretions become thick, sticky, and obstructive. Imagine trying to push toothpaste through ducts designed for water. Not happening. While lungs get the spotlight, the pancreas is heavily affected, leading to pancreatic duct obstruction, enzyme deficiency, fat malabsorption, and failure to thrive. This loops directly back to our previous slide. CS is a major pediatric cause of malabsorption. It's a full circle moment. Classic findings include dilated ducts, inseparated mucus, acinar atrophy, and progressive fibrosis. Over time, the pancreas can become almost completely replaced by fat. Yes, the pancreas basically rage quits. Worthless but memorable knowledge: before modern therapies, many children with CF were historically described as having salty tasting skin. Parents noticed it before medicine understood why. Science eventually confirmed elevated chloride in sweat. Sometimes observation beats technology. Let's talk about celiac disease, which is one of those conditions that looks deceptively simple on paper, but is actually pretty fascinating from a histology standpoint. At its core, this is a gluten-triggered autoimmune injury occurring in genetically predisposed individuals. Gluten, found in wheat, barley, and rye, kicks off an immune response that essentially tells the small intestine, hey, attack yourself, which is not ideal. Now here is where your histotechnologist brain should immediately go. What structure is responsible for absorption? The villi. And what happens in celiac disease? Villus atrophy, crypt hyperplasia, increased intraepithelial lymphocytes. So instead of a lush shag carpet absorptive surface, the mucosa becomes flattened, more like cheap office carpet. Surface area drops, absorption drops, and patients develop symptoms like diarrhea, bloating, and fatigue, and sometimes, surprisingly, minimal symptoms. A fun histotech pearl, duodenal biopsies for suspected celiac are often tiny and delicate. Orientation matters a lot. Poorly oriented tissue can completely mask villus blunting. This is one of those specimens where embedding skill directly impacts diagnosis. Now notice the red text, increased risk of malignancy. Chronic inflammation increases the risks for enteropathy-associated T-cell lymphoma and small bowel adenocarcinoma. So untreated celiac isn't just a dietary inconvenience. It can become a serious long-term pathology driver. Some worthless knowledge moments. Oats themselves don't actually contain gluten, but they're frequently contaminated during processing. So oats are basically innocent bystanders with a very bad reputation. If celiac is a slow burn, ischemic bowel disease is a vascular emergency. This condition happens when blood flow to the intestine is reduced or completely cut off, leading to infarction. Remember, intestinal epithelium has a very high metabolic demand. It does not tolerate hypoxia well. Think of it like brain tissue. No oxygen results in rapid cellular injury, which results in necrosis. Grossly, the bowel may appear hemorrhagic, dusky or purple, edematous, or ulcerated. One classic feature is the sharp demarcation between viable and non-viable bowel, almost like someone drew a line saying, life stops here. From a histology perspective, you might see mucosal sloughing, coagulative necrosis transitioning towards liquefactive change, hemorrhage, and ghost crypts. And if progression continues, perforation, peritonitis, and surgical emergency. Histotech tip: these specimens often arrive fresh from surgery and may be thick. Adequate fixation is critical, otherwise the mucosa autolyzes quickly and becomes very difficult to interpret. Analogy: imagine kinking a garden hose supplying water to your lawn. The grass dies fast. The bowel is even less forgiving. Take a good look at these specimens. What should jump out immediately is the color change. That dark greenish black discoloration is a huge red flag for infarction and necrosis. Healthy bowel should look pink and glistening. This, not glistening, not happy. Notice the thickened wall. That's edema and hemorrhage contributing to the swelling. Also observe the luminal surface, irregular, dull, and necrotic rather than smooth. When you see tissue like this engrossing, your internal monologue should be, this bowel has had a very bad day. Necrotic tissue can be friable, so gentle handling prevents fragmentation and tissue loss during processing. A worthless but memorable fact: surgeons sometimes describe infarcted bowel as having a smell you never forget. I will spare you further sensory details. You're welcome. Ischemic bowel disease. This condition tends to affect older adults, typically over 70, largely because vascular disease accumulates with age. The presentation is often dramatic: sudden cramping abdominal pain, urgent desire to defecate, and passage of blood. That abrupt onset is your clue that this is vascular rather than inflammatory. Mortality sits around 10% within the first 30 days, which should reinforce just how serious bowel ischemia is. Early recognition matters. Patients may initially look stable, but bowel can deteriorate rapidly once perfusion drops, which is why surgical teams act quickly when ischemia is suspected. Histotechnologist takeaway: when you hear rule out ischemic bowel, expect large resections, multiple sections submitted, and requests to evaluate margins for viable tissue. Because surgeons need to know, did we remove enough? Now we are shifting into inflammatory bowel disease, or IBD, which is less of a single disease and more of an umbrella term for chronic inflammatory conditions of the GI tract. The two heavy hitters here are Crohn's disease and ulcerative colitis, or UC. And while they share some clinical overlap, histologically they behave very differently, which means you, as future histotechnologists, play a major role in helping distinguish them. Let's start with the visual. Notice how Crohn's disease shows skipped lesions. That means diseased bowel segments are interrupted by completely normal tissue. It's patchy, almost like someone spilled inflammation randomly along the GI tract. Fun analogy, think of Crohn as a pothole road. Damaged areas, then smooth pavement, then another pothole. Crohn inflammation is transmural, meaning it extends through the entire bowel wall. Because of that depth, you can see fissures, fistulas, and thickened bowel, and also strictures. From a grossing standpoint, that bowel can feel almost rubbery. Now compare that to ulcerative colitis. UC is predictable, almost polite by pathology standards. It always starts in the rectum, moves proximally in a continuous pattern, and is limited primarily to the mucosa and submucosa, and there are no skip areas. Histology tidbit you should absolutely file away in your brain. Pseudopolyps are classic for ulcerative colitis. They aren't true polyps, they're islands of regenerating mucosa surrounded by ulceration. Some worthless but memorable knowledge: early pathologists thought they were tumors. Turns out they're just overachieving tissue repair. A histotech forward note: when embedding suspected IBD biopsies, orientation matters. Poor orientation can obscure mucosal architecture, crypt distortion, and inflammatory patterns, all features your pathologist needs to make the call. You are not just cutting tissue, you are preserving diagnostic architecture, and architecture is everything in GI pathology. So what actually causes IBD? Short answer, the immune system gets a little too enthusiastic. Long answer, IBD is believed to result from a dysfunctional conversation between the intestinal microbiome and the host immune system in genetically susceptible individuals. Basically, the body starts treating normal gut bacteria like hostile invaders. Imagine living in an apartment building and calling the police every time your neighbor microwaves popcorn. That is IBD level immune overreaction. Now let's talk demographics briefly. IBD commonly presents in teens and in early adulthood, which is important clinically because chronic disease at that age carries significant quality of life implications. You'll also see higher prevalence among individuals of European descent, though incidence is rising globally, likely tied to environmental factors and microbiome changes. When reviewing IBD biopsies, pathologists are often looking for crypt abscesses, gland distortion, basal plasmacytosis, and granulomas, think Crohn. Your section quality directly impacts whether those features are visible. Again, no pressure. But truly, chatter, folds, incomplete ribbons, or thick sections can hide subtle inflammatory patterns. A big clinical takeaway: IBD is chronic, relapsing, and currently not curable, only manageable, which means patients often undergo multiple biopsies over their lifetime, and that makes consistency in tissue processing incredibly important. Future you in the lab becomes part of that patient's long diagnostic story. If malabsorption was about not absorbing nutrients, IBD is about the bowel being stuck in a constant state of immune drama. Different mechanisms, the same end result. We have damaged mucosa, impaired function, and patients who rely heavily on accurate pathology. And as always, histology doesn't just support the diagnosis, it drives it.